the most important diagnostic tool for a urology, especially for the lower urinary tract, is a cystoscopy. We learnt at the beginning that the conventional cystoscopy is expensive because it has three components. The most expensive part, which is the telescope, then there is a bridge, and also there is a sheath which varies in several sizes. And then on top of that you need the camera, the light source, the monitor. All these things make it so expensive. It is difficult for non-urologists to afford it. And that is the reason we have come up with this low cost laptop cystoscope, which does not need all these things. All that we have done is replace the telescope with the endoscopic camera, and we still have the bridge and the sheath which are used. And because this is a surgical procedure, it is very important that whoever does it takes a proper informed consent before starting the procedure. There is possibility of a little bit of bleeding after the procedure, and rarely the possibility of injury and stricture. So, all these things should be explained to the patient while taking a consent. And in general, in rural areas, we prefer to use prophylactic antibiotics, just aminoglycoside like gentamicin or cephalosporin, or even oral ciprofloxacin could be given. And then in men or women, generally it is preferable to do it in a lithotomy position and clean and rape as for regular conventional surgery, because it is a sterile procedure. The scopes can be sterilized using the glutaraldehyde or Cydex, and here in this scope also there is a portion which can be comfortably immersed in Cydex. This is a wire, and while this is covered with the waterproof coating, so you can immerse and sterilize in the Cydex. And then here it is okay, but in conventional cystoscopy it is important, especially we have a camera, to make sure that the 12 o'clock position is correct. So, generally we hold the camera fixed, and then you can move the scope to 9 o'clock or 3 o'clock position to see wherever you want to do. But here that problem is not there, because it is a fixed and 12 o'clock position is up there. So, we can turn to look at the 9 o'clock position, or this way to look at the 3 o'clock position. And the way to do is that, especially in men, you need to hold the penis like this between the 4 fingers like this, and you can use the thumb and the index finger to spread the urethral meatus. And then you have to remember that from the bladder there is a curve. So, bladder is here, urethra comes and then curves up. So, you do not want to pass through two curves. So, you need to hold the penis like this, it is straight. And then while doing scopy, it generally sometimes the telescope or the camera here sticks out, and it can cause injury, and this is the most smooth part. So, you need to lubricate well and pass like this, and then straighten it to 12 o'clock position. Okay. Then you can see the picture in the monitor, and you should gently pass the scope under vision. So, if you see like this, you should not push. If you see like this, you should not push, because that can cause injury. So, here gently pass, and then this may be the sphincter level where you have to turn up and then go into the bladder like this. So, once you reach the bladder, you look at the bladder neck and the interureteric ridge, and then the two ureteric orifices which is simulated here, and then you can have a look at the dome. You can turn the scope and press the bladder to have a look at the dome, then the 9 o'clock position and 3 o'clock position. So, all over you need to have a method of comfortably and accurately seeing the entire bladder. Then while removing again, you need to follow the curves and take it out under vision. So now we'll have a look at the, turn to your right and have a look at the slides. We'll show you some of the abnormal findings. What you see here is the stricture. The normal urethra is about 30 French or 1 centimeter in diameter, and this is will not even allow a small infant feeding tube to go through. So here, this is why it is dangerous to do blind urethral dilatation. You need to pass a guide where once it reaches the bladder, cut the strictures under vision. So this is how, this is called bilobar obstructive prostate. So you can see the prostate blocking. If you see the verumontanum, and with the scope, if you look from the veru, say imagine this is the veru, you should be able to get into or see the scope comfortably. But if the prostate is enlarged like this, you will not be able to do that. And then the next important thing is to locate the ureteric orifice. From the bladder neck, if you look down, you will see the interureteric ridge, which you trace on either side, and the orifice will look like this. The diagram you can see there. And then these showing some of the hypertrophied detrusor muscles, and the trabeculated bladder can also have these sort of mucosa which bulges through the muscles. And this is how a seaweed appearance, or this is how a bladder tumor, transitional cell tumor will appear. And here actually you can see a vesicovaginal fistula. You may be able to come through the vagina into the bladder also to have a look at it. And these are tuberculosis. It can actually, TB can mimic almost anything. People have mistaken it for malignancies and a lot of other conditions. But this is one other way in which TB appears. And this is not an uncommon way vesical calculus looks. Stop. So, actually, the next one will need one more. We need an assistant. Goldie is not coming back, no? So, we have DJ stenting to record. That probably we will record tomorrow when there is an assistant. And if we have time, then we can start recording this one. No, for double J stenting, there is one more part of the urology left, but that I need an assistant. So when somebody is there tomorrow, then we will record that.
For what? The last part?
Last part. But then if you want, we can record setting up the raised device. Are you recording with this camera also?
No.
Maybe for the raised device, what you can do is we will record with that, and can you record that separately and this at the same time? Same feed? The total thing and just that?
Sorry.
Or we have to do it again?
Just need to end this one. Is that one of your last slides? The prophylactic antibiotic?
No.
Where is it in the slide?
That's somewhere in the beginning.
The beginning?
Yeah. We not recorded after that.
Yeah. Oh, there you go.
Last stage will be vesicle calculus. And that's the last stage.
Yes,
But
that's
we didn't talk about it.